I think what's the most exciting data emerging from this year's ASH is the impact of immuno-oncologic drugs in myeloma. And what I mean by that is the impact on the one hand of elotuzumab combined with lenalidomide-based therapy, the impact of daratumumab, both as a monotherapy and in combination with immunomodulators. And I think also this very early but very promising data of PD-1 inhibition combined again with lenalidomide-based therapies. And I think the fact that we're seeing a very consistent signal suggestive of clinical benefit in some of the early phase trials and confirming clinical benefit in the randomized phase 3 setting is very provocative. I think set against that, Debbie, is also the really remarkable data emerging for ixazomib as the first-in-class oral drug in the proteasome inhibitor space to be tested in a phase 3 setting and show clinical benefit and so lead to approval. So I think in terms of 2015, we've had an extraordinary year, 7 drug approvals in 1 year. It's a record. In the last month, we've had 3. And I think that points to a momentum of progress in the disease which is unprecedented. And it's no surprise then that the last 3 drugs approved have been daratumumab, ixazomib, and of course elotuzumab, 2 monoclonal antibodies and the oral proteasome inhibitor. And I think prior to that, of course, was the full approval of pomalidomide, the full approval of carfilzomib in combination with lenalidomide, the approval of panobinostat as an HDAC inhibitor, and of course also the approval of lenalidomide as upfront therapy and maintenance. So a lot of the data at the meeting sort of builds on all of this. And the data at the meeting builds upon the success of HDAC inhibition, be it with panobinostat or some of the very early promising data from more HDAC6 selective molecule, a so-called ricolinostat, and in its new form AC241. So there's HDAC space, which is very exciting, particularly with those 2 major drugs, panobinostat in an earlier stage, the AC1215, 241 molecules. I think then into the immunology space, we've talked a little bit about the antibodies already and the checkpoint inhibitors. That's dramatic. And I think what really jumps out at me about, for example, the elotuzumab data is when you look at immuno-oncologics, you look for durable benefit. And what we're seeing with elotuzumab in the randomized setting is a consistent progression-free survival benefit that lasts. And now we're seeing a strong trend in favor of overall survival. And what's really nice about elotuzumab is it's very well tolerated. Ultimately, it becomes a 1 to 2 hour infusion. It starts at about 3 hours, but once it's tolerated, it's a 1 to 2 hour infusion. It's initially every week, then every 2 weeks, and then in the maintenance schedule, it can even be monthly. So there are lots of ways of using these drugs in a way that's very convenient for patients. The daratumumab data, which obviously there's a longer infusion time for daratumumab, it's about 6 hours usually. Great drug. In terms of single agent activity, we're seeing responses when everything else has failed, and I think that's amazing. I think the combination data to me, though, are the most compelling. They show that when you combine daratumumab with other agents such as lenalidomide, you see dramatic responses, and we also see great responses when you combine daratumumab with pomalidomide. So I think for patients there's some real promise that not only are we making real headway up front, but we're making real headway in the context of relapse. Now, I think the other very interesting message from the meeting goes along the following lines, which is that we have an exciting data from our French colleagues coming out about the early interpretation of the French study looking at early versus late transplant. And I think what's interesting there is they're clearly showing a progression-free survival benefit in favor of early transplant. We all expected this. And the study was designed to show 4 months or more, and it actually shows 8-month progression-free survival in favor of transplant, which obviously is good news. Having said that, there is no survival difference. And if you look at the 2 arms for survival, the non-transplant arm has, at a median follow-up of over 4 years now, at an overall survival of 83%, and the early transplant arm is at 80%. So there's no difference in survival. The results are excellent for both arms, but there is a progression-free survival benefit. Now, the critical challenge in the French study is that for various reasons, the maintenance was fixed at 1 year. So what that meant was you only got a year of lenalidomide therapy. And we think that's very important because when we look at the MRD data that sits with the trial, whilst the minimal residual disease negativity is higher for the transplant arm than it is for the non-transplant arm, the MRD negativity improves over time with the effective therapy. So I think the US trial, which runs in parallel to the French one, which continues to actively enroll, becomes so important because there, of course, we're looking at maintenance until progression. So this continuous therapy model continues. And also, of course, we're looking in the context of US practice. That's tremendously important because in the US, there is a real desire from patients to wait on transplant in a number of patients, to say, why would I want to rush into this? Why wouldn't I collect my stem cells and see what happens? And what we hope to do with our trial is demonstrate clearly what is the best strategy for particularly younger patients as a whole, but most importantly for subsets, because I think what we strongly feel in our center and in our research team is that one size does not fit all. And I think whilst clearly the French data are provocative and support early transplant, as we said in our discussions with the group together today, clearly it may be that subsets of patients can afford to wait and others may in fact need to go early. And the trial will have to sort this out, we hope to, in the US context. I would say that in the French context, because they limited their maintenance therapy, it would be, I think, wholly premature to extrapolate from their experience and say that therefore applies to US practice. I think that would be a mistake. So very encouragingly in the US trial, we've accrued now 540 patients. We have 120 to go. And I think we feel very comfortable about continuing the study because it's really an excellent choice for patients, because we really don't know whether or not early versus late in the context of American practice results in a big clinical benefit in favor of one versus the other. Obviously, an 8-month progression-free survival benefit is important, no question about it, but it's 8 months. And if there is no survival difference, you have to then ask the question, okay, what does continuous therapy do in that mix? And I think because we have continuous treatment as part of our study, it makes this so critically different to the French experience. So I think the French experience is incredibly important. It's a great partnership. But I think, as Dr. Attal himself said, the US trial is crucial. And I think going forward, that's going to be very important to complete. It will inform practice for future patients for many, many years to come. And I think it will provide a platform for further discovery and practice-changing strategies. So in this context, I think what's so important to understand about the trial, in both the determination trial and other trials such as the SWOG study, which clearly show that RVD is better to RD, is that there's a continuum of progress. And so on the one hand, whilst we've shown that RVD plus transplant results in progression-free survival benefit, and we'll wait and see what continuous therapy does, and indeed what in the US practice, our study shows, it's a huge platform for the future, because the obvious next thing, Debbie, is to add to RVD or an equivalent. So could you add a proteasome inhibitor of the next generation, such as carfilzomib? Could you add a proteasome inhibitor of the next generation after that, namely ixazomib? Could you then put an antibody into that platform? Those are huge questions, because in fact, what they may do is change the whole paradigm again. Because what we do know from the French analysis is not only does MRD improve over time with continuous therapy, that's clear, we also know that complete remission really matters. And achieving MRD negativity really matters regardless of which arm you are assigned to. And why that's so informative is it tells you that strategies that can drive a deeper and longer and more complete remission and last longer may actually now set a whole new spectrum of questions that we need to answer to improve patient outcomes. So a very exciting time with lots of new advances and an implication that goes beyond just the relapse refractory setting but comes into earlier disease as well.